Hello everyone, good evening and a very warm welcome to Critical Care Unplugged. Thank you for taking the time to join today. The most common drug in the ICU has no dose. Every day it saves life or silently causes harm. Fluids are powerful, given reflexively, they flood organs, given thoughtfully, they restore perfusion. In modern era of critical care, the question is no longer should I give fluids. It is who truly needs them, how much is enough, and when is enough too much. If you ever paused before the next bolus and wondered, is this helping or harming? This session is for you. That brings us today. That brings us to today's session: perfusion over pressure, rational fluid therapy in shock. Today we'll explore how to balance perfusion, pressure, and fluid tolerance using evidence, bedside tools, and real-world ICU experience. We are privileged to have an expert panel with us who will challenge long-held assumptions and discuss the gray zones of fluid therapy and share practical insights that can directly influence our daily practice in ICU. So I'm Dr. Bharat Jagiasi, going to moderate this session, and I'm Director of Critical Care Department, Co-Club in Dhirubhai Ambani Hospital, Navi Mumbai. And we have the panelists along with us. To start with, we have Professor Manu Malbrain. Professor is internist and intensivist, graduated from Catholic University, Belgium. He has been ICU director and hospital chief medical officer in different hospitals in Belgium in the past 30 years. He's also been an associate editor for Annals of Intensive Care, executive board member, European Sepsis Alliance, co-founder and treasurer, Abdominal Compartment Society, co-founder and president, International Fluid Academy, we all are aware of. His work in fluid has been acclaimed and known by everyone in critical care. Welcome, Professor, to this Critical Care Unplugged.
Welcome, Bharat, and thank you for the invitation.
Thank you. Next, we have Professor Dr. Sunil Karanth. Dr. Sunil Karanth is Chairman of Critical Care Services, Manipal Health Enterprise Private Limited, Head of Department and Senior Intensivist, Manipal Hospital. He's Adjunct Professor in Critical Care Medicine at Manipal University, former Chairperson and Treasurer of Bangalore Chapter, Indian Society of Critical Care Medicine, winner of various awards, Namma Bangalore Award. He's also a member of Karnataka State Critical Care Support Team. Welcome, Dr. Sunil Karanth, to Critical Care Unplugged.
Thank you, Bharat. Good to be here and good to be part of the panel. Thank you very much.
Next, we have Dr. Supradip Ghosh, someone who's been working for past several years to promote rational prescription of oral and intravenous fluid, organizing workshops in and out of ICCM fold. Author of book we all are aware of, Handbook of Intravenous Fluid, which is conceptualized, multi-author and multi-country book. Even the Professor Malbrain joined him as an editor in 2019, and book finally came to light in 2024 under the banner of IFAD. Teacher and examiner of DRNB Critical Care Exam, currently working as the Director and Head of Critical Care Medicine, Yatharth Hospital, Noida. Then we have Dr. Apurba Bora. Dr. Apurba is consultant and head of the department, Critical Care Medicine, Narayana Super Specialty Hospital, North Guwahati, Assam. He has more than 20 years of experience in the field. Welcome, Dr. Apurba and Dr. Supradip.
Hi.
Hi.
Thank you, Bharat.
Hi, sir. So then we have next panelist we have is Dr. Pankaj Soni, Director of Critical Care EMC Hospital Group of Hospitals, that is Amritsar, India, General Secretary of Punjab ICCM, and has published national and international publications written various chapters. Welcome, Dr. Pankaj.
Thank you, Bharat.
Yes. So let's start with the panel. So we all are aware of, especially Professor Malbrain, you have worked across different ICUs and health systems globally. And from your experience, is there really a perfect fluid strategy that works for every ICU patient? Are you aware of that fact? If yes, then why? And if not, then what is the reason of it?
Okay, thank you. This is a very interesting question. Everyone knows about the perfect storm, but the question here is there a perfect fluid or a perfect fluid strategy? I don't think there is an ideal fluid and there is no ideal strategy, as fluid administration is context sensitive. And as you already mentioned, fluids are drugs. So we need to take into account the type, the dose, duration, de-escalation, And the context will probably will be determined by the terrain and comorbidities. Or as if you wish, the heterogeneity and different phenotypes within patients. So I'm not a fan of standardizing fluid therapy, nor protocolizing it like the SCC Society Critical Care Sepsis Guidelines, but I'm rather into personalization and maybe even better individualization. So the difference between the latter two is that personalization takes into account previous hypertension, and I think we will discuss that, and maybe we need other thresholds, whereas individualization is dynamic and on day one may try to focus on macrohemodynamics, blood pressure, but on day two we may look at the lungs and so forth. So that is the way to go, and probably in the future we will have closed loop artificial intelligence algorithms to assist us when and why to give fluids, inotropes or presses.
Yeah, yes.
The answer is no.
No. And you gave us the reason. So that is what I was coming to. So the next is we talk about the physiological goal of the fluid therapy. And Dr. Ghosh is someone who's championed rational fluid therapy along with you. So Dr. Ghosh, what do you think should be our primary physiological target when giving fluids?
So probably it depends upon the reason for why we are giving the fluid. If we are giving the fluid for the purpose of resuscitation, then the ultimate goal is to achieve the perfusion of the tissue and the organs. That's the ultimate goal. If it is for the purpose of maintenance, the ultimate goal is just to maintain the internal milieu so that the adequate fluid balance for a particular person is maintained, along with the electrolytes, and to provide a certain amount of glucose so that gluconeogenesis doesn't take place. If it is for the purpose of dilution, drug dilution, then again, it is only for the drug dilution. So we need to see what is the goal we want to achieve, or if it is for the replacement, we want to replace whatever volume of fluid has been lost. For example, a person is losing from cholera, we need to replace whatever volume has been lost through the diarrhea and the vomiting. So that depends upon what is the reason behind a particular intravenous or oral fluid prescription. So,
yeah, thank you for that. And I would like to have one more view on this. Dr. Apurba, would you agree from your ICU experience in a different setting? I mean, what is the primary physiological goal of fluid therapy you think of?
Yeah, very interesting question, and it has been answered already. Because see, why? What is the reason you are using? Is it a resuscitative or is it a maintenance, right? So to make it very brief, I think perfusion, because whether you are using fluid, basic aim is perfusion, and so that the oxygen delivery to the tissue is improved. Basically, as we are talking about fluid therapy, we need to make the person euvolemic. That is what it is. It's like, a fluid responsive heart to make an efficient heart, right? And this is the basic thing. The fluid can itself do a very important part of overall resuscitation. And that is what I think is the primary goal, right? The perfusion and delivery of oxygen.
Yes. So as he said, we need to know about the various reasons Dr. Supradip said, whether we are using as a diluent or as a fluid recipient or maybe as a therapy, and accordingly we'll decide our goals. So we come to our next question. We always talk of this why is fluid responsiveness and not same as a fluid requirement. So Dr. Sunil, many of us use various dynamic indices, could be the positive response. So does it mean always that fluid responsiveness is the fluid requirement? So anyone who is responsive will need fluid, or we have to transfer fluid, Dr. Sunil?
So the obvious answer is no. In fact, if you look at normal human physiology, it is always in a fluid responsive state because we are preload dependent. In a normal person, I'm talking about the normal heart is preload dependent. So, but I think the bottom line is if you look at all protocols which talk about assessing fluid responsiveness, the caveat is in a person who is hypotensive or in a person who you think there is hypoperfusion. That's the first caveat. So I think the question number one is, first of all, is there an indication to give fluid? And then we see if the fluid is going to be beneficial or not. I think we have moved away from the concept of fluid requirement to more towards fluid tolerance and whether giving fluid will help or cause more harm. I think that's where all these dynamic indices have been devised, because a given patient or an individual may need fluid. If you look at the deficit, for example, there could be a calculation based on the old time formulas or other sort of physiological formulas. If you calculate, you might find that there is fluid requirement. But the fundamental answer that we need to get before we give fluids, as you have already mentioned in your opening remarks, that fluid is a drug, overdoing it is bad. And is there an indication to give fluid, and will the giving of fluid help? That's what we look for when we talk about fluid responsiveness and fluid tolerance. I think that's the question that we need to answer, that if I give fluid, will it help or will it cause more harm? And if the answer is the latter, then we have to think twice or, really calibrate our fluid administration.
Yeah, so also we come across the situation, many of us would be the fluid responsive as well, because we do not fill our compartment to the maximum, but it doesn't mean we need a fluid if our
True,
perfusion is
true.
good enough. Yeah.
Yes, yes.
So
In fact, if you look at all our healthy volunteers who come for all our POCUS workshops, I'm sure you will find that the VTI
yes,
is low. They will be having a degree of LV kissing. It is all because that's how the preload state is. And that the reason that is because of the venous capacitance, which gives us that immense reserve. So just because you find this finding, it's not appropriate to give fluid. So I think the fundamental question, as I said, is the opening caveat, that is a person requiring fluid based on indices to say that yes, the person is hypotensive, hypoperfusion. Then you go through the necessary sort of algorithms of uh, whether the benefit of fluid is there or not, and that's where all these dynamic indices have evolved.
yes, that's true. So volume load itself is not enough. We need to look at
Definitely.
the reason for the requirement, and of
Correct,
course, it
correct.
requires also then we have to look into the tolerance level
Yes,
as
yes.
well.
So even if there is a requirement, will he benefit? Will he tolerate? I think these two fundamental questions we need to answer.
Yes, thank you. So now we move to the next question. We have the Andromeda 1 trial, and now we have the Andromeda 2 trial, which is the personalized hemodynamic resuscitation. We'll talk of it a little later. So here we all know capillary refill time links cardiovascular function to tissue perfusion. So Dr. Pankaj, in a busy ICU, though the Andromeda trial has shown maybe the CRT is not inferior or maybe better in terms of the immediate result when it compares with the lactate. So CRT is simple and fast. So why is it more often useful than lactate in real-time decisions? I mean, why this conclusion?
As already all the panelists had conveyed that our main aim is to have the perfusion. So when we are giving some fluid as a drug, so the CRT is more of a real time bedside readout of the peripheral perfusion. So it is very easy to monitor that how much fluid I need to give to my patient as compared to lactate. When we are measuring lactate, there are so many variables which comes in the lactate because it is slower and adrenergic effect. Drive can also change the lactate, and we have to draw it from the blood. The CRT is more of a real-time image what we get, and the uh, capillary refilling targeting has been studied as a resuscitating guide. So we can guide our fluid. Uh, but the lactate, the reading, the change in the lactate will come with the time. It will take relatively more longer time for the lactate to be present, to decrease in the blood. So CRT is a real time, and it give us more valuable information. As you already mentioned that the trials were are also showing that CRT is a better indicator as compared to lactate.
So yeah, it's a very good answer. Request to the participants, especially the Kashif and others. I mean, you're scrolling over here. We could see it. If you could stop that. Very well said. CRT, of course, lactates are the bilinear curve, as we all understand it. goes
Yeah.
low, then it takes a plateau. So this is the reason why sometimes it takes longer to the correction, and CRT usually gets correct within 15 minutes or the once we achieve the perfusion. And also we have to draw the blood again and again. Lactate correction might take time. CRT is a easy way to do it, but of course CRT has again the learning process. There's a variability, heterogeneity amongst the different colors and skin. So once we learn over it, CRT maybe will be the better marker in terms of looking into the perfusion. So when we talk of the next, that is, we look into the hemodynamic incoherence. So Dr. Sunil, can you explain about the hemodynamic incoherence in practical terms, what exactly it is, and if you could tell us about the different phenotypes and how they influence the treatment of it?
Yeah. So I think fundamentally for many decades we have looked at hemodynamics in the gross terms of macro hemodynamics. I think your blood pressure, cardiac output, CVP, all these things largely suggest macro hemodynamics or macro changes. But we need to understand that in various pathological processes that happen within the body, and particularly the most common that we are aware of is sepsis, and that can hold good to a lot of other things. The fundamental thing that we see is that there is a disconnect between the macro circulation indices and the microcirculation indices. And with the macrocirculation, it is the gross average out of the different tissues that we are actually seeing, or the different tissue beds which we see. So if you even if you say we are looking at lactate, or we are looking at MAP or any other index, what we generally see is the gross sort of macrocirculation indices. But many times you correct the macrocirculation index, but you might find that it is not reflecting in the microcirculatory change that we are expected to see. So that's where the fundamental sort of disconnect lies. And the reason for it is, of course, numerous. I think if I start going listing, you can have a separate session on that, because we do know that the process of inflammation or any other response of the body for a given stimulus is going to be multifocal. There are changes in the vascular reactivity which are different in different beds. There are, there could be vasoconstrictive situations, vasoplegic situations, microthrombi, the endothelial dysfunction that itself produces, that happens, kind of keeps the propagation of the inflammation going, or or anti-inflammatory system going. So there is a lot of it's a cascade of events that happen, and the different responses of each of the tissue circulate of the microcirculation of the different tissues plays a role. The local microcirculatory reflexes also plays a role. So what you might see in the lung may not be the same in what you see in the liver, though we have made different attempts to look at this in the form of different kind of microcirculatory studies, that we look at the sublingual videoscope, for example, or looking at the capillary refill, as you just now said. So the disconnect that lies between the macrocirculation and microcirculation, the short of it is what is the problem that we face, and that is what we cause as hemodynamic incoherence. So different authors have looked at it from different angles, and they have come up with different kinds of sort of phenotypes. A lot of frameworks have been described as well. The most sort of summarized version of it is what is called as the sloop phenotype, which looks at the 5 gross phenotypes. One is sloop, stands for stasis, leakage, occlusion, and occlusion, obstruction, and paralysis. So when we talk about stasis, it is more in the form of venous congestion in those patients who are either tissue overload or right heart failure, congestive heart failure, etc. When we talk about leakage, the typical sepsis that we talk about, a very leaky capillary state. Now, sepsis is the most common example that we know of. Of course, it could be any other SIRS response states, autoimmune phenomena, whatever it is. Then we talk about occlusion, which is again microthrombi obstruction, which happens at the microcirculatory level. And of course, obstruction itself is which can be a part of endothelial swelling and the procoagulant state that happens as a part of endothelial activation. And the last, of course, is the paralysis, which we talk about is more like vasoplegia. Now, the vasoplegic states also, you have lots of shocks where you do find vasoplegia happening, which could be things like, anaphylaxis or just sepsis itself. So these 5 categorizations again can be sometimes quite gross, because you might actually find different, different circulatory disturbances in different tissue beds as well. So the gross summary that we see in the macrocirculation may be depending on which is the predominant sort of tissue which is causing the effect, or a sum total, or the algebraic sum total of all of this. So if you look at how are we going to manage it, I think it will be largely based on what is the predominant phenotype that we talk about. So if you say it is vasoplegia, there could be a role for steroids, or there could be a role for vasoconstriction. If you talk about a situation where there is obstruction or inflammatory kind of a thing, maybe there could be a role for either a steroid or an immunomodulator. And of course, if it is leakage, again we talk about controlling the fluid that we are going to administer, and the same holds good for a stasis or a tissue congestion. So based on these phenotypes, there is a gross sort of there's a little bit of a personalization of or precision of personalization of the strategy that we can use. Now, how do we look at that? Is probably we have to look at a combination of symptom, signs, and investigative modalities or monitoring modalities, which could go from clinical symptoms, your gross macro dynamic monitors like dynamic indices, which we already spoke about, echo, tissue congestion parameters, and even for that matter, the videoscope based tissue based character, looking at tissue beds study of the microcirculation like sublingual or skin or tissue oxygenation levels. I think a combination of all these was something that we may use. And of course, people are looking at AI, trying to simulate, trying to assemble or put all these information together and come up with which is the best kind of approach when we talk about managing the hemodynamic consequence.
So yeah, very nicely said. So if I have to summarize it for everyone, so as you said, when there's a situation where macrocirculatory targets like blood pressure and cardiac output will improve, but microcirculatory targets like perfusion and organ function do not. This is what the hemodynamic incoherence is.
Incoherences,
Yes,
yes.
and we look at the different phenotypes. It's perfusion pressure mismatch, where BP will improve, but organs will remain hypoperfused. So
Yes.
MAP will be good, systolic pressure will be good, but there will be CRT will be hampered, urine output will be hampered, lactate will be hampered. So in those
Okay.
situations, instead of increasing the blood pressure, vasopressors, we have to look for the other causes. That again would be the flow versus the utilization mismatch. Where the
Correct.
oxygen delivery is adequate, but the tissues
Yes.
cannot use it. So maybe we have to prioritize source control or metabolic support rather than just fluid and the inotropes. And
True.
again, very rightly you said the microvascular shunting. So the blood bypass the capillaries, but organs do not get oxygenation. So here,
Correct.
in fact, we have to be very careful. We have to optimize perfusion carefully and advise avoid excessive.
So here also, whether it is just a microcirculatory failure or a part of tissue congestion, because both have different kind of,
Yes.
uh, you know, uh,
So tissue congestion, we have to
yes,
stop fluids and in fact
approaches. Yeah,
resuscitate with the diuretics or maybe the CRT and optimize the right
true.
ventricular function. Yeah. Yes. So we'll come to the next question. That is when you talk of the subgroups of patients which may benefit from the higher map targets and why is this beneficial? So Dr. Pankaj, in which patients do you aim for higher map and why doesn't this strategy work for everyone?
See, mean arterial pressure is not always to be used as the only indicator, right? So, like in few cases where you are having AKI, or in the cases where you are having neurotrauma, so you need to maintain a higher map. So the mean arterial pressure should guide you, right? It is it is not something that you should always stick to it, that I want to maintain a 65 mean arterial pressure. So sometime in the cases of uh, lower renal perfusion and the hypertensive patients, the auto-regulation is already disturbed. So in these particular set of patients, the to maintain the adequate auto regulation in these patients, we need to accept the higher mean pressures, like in these patients, and it is not always consistent. So if your patient is having good perfusion at a mean arterial pressure of 65, it's okay, because our aim is not to give fluid. Our aim is to maintain the adequate perfusion, and at the same time treat the underlying cause. Whatever be the cause of the hypotension or the shock is there, we need to treat that. And when we are treating the disease, along with that we have to maintain the adequate perfusion. Wherever where our adequate perfusion is maintained, and say a mean of 70, and we are our lactate is fine, CRT is okay, and our all other SpO2 and all other parameters, they are looking fine. IVC is euvolumic. So that is the point where you should maintain a mean arterial pressure. I will not go for a very strict dictum of having a mean arterial pressure of 65 for this particular case. I will individualize, and it is a very individual approach whenever you are treating a patient. We should not have a fixed idea about this mean arterial pressure.
Again, request to Dr. Piyush, who is logged in as labeled as Dr. Piyush is trying to scribble, if you could please avoid it. So very rightly said Dr. Pankaj Soni, we have to individualize it and personalize it. But at the same moment, as we also understand about the auto-regulation and about in case of the CKD patient, hypertensive patient, we have to measure the map. We had the Optrus trial which came in and which told us maybe higher map is more harmful. So Dr. Supradip, how long should this map be performed to assess meaningful changes in organ perfusion in contrast to the Optrus trial, what it told us higher maps were not beneficial when they maintained in certain group of patients?
I think there is a fundamental problem with this targeting a particular type of map and randomize these patients into two groups. One group received this. We have a 65 trial. 65 centers,
Yes.
65 years of age group, 60 to 65 is the target. So none of these are going to help. None of this, because they are not targeting the an individual patient. So what we have seen, the sepsis palm trial, which was probably the most famous of this trial from France, where they found that higher MAP target is better for patients who are previously hypertensive. But they have not mentioned whether these previously hypertensive were well controlled with antihypertensive medications. And if you see in details of both the groups actually had a much higher blood pressure compared to what they were supposed to have. Similarly, 65 trial failed to show any benefit of things. So I think targeting MAP has to be individualized. I think some amount of insight was provided by many of these small studies from Latin American countries, and where, again, the Andromeda Shock 1 has given a protocol. Again, I am not a great fan of protocol. It has to be personalized, as Manu has pointed out. I totally agree, not only for fluid, for everything in ICU and everywhere. But this Andromeda Shock 1 trial has given us a larger thing, which is not a unique thing for Glenn team. It was actually there earlier also. So what I suggest is that this vasopressor challenge is a very interesting concept, but we need to see it in other things also. Maybe we increase the blood pressure, a map from a particular of 60 to 65 to maybe around 85 to 90 or 80 to 85. Why they have given 80 to 85 to 90? Because in the sepsis palm trial, the patients in the higher MAP group had a target of 85 to 90. So they provided so go for this. Wait for half an hour if you are following CRT. Wait for 2 hours if you are following a lactate. And if you find that these patients MAP with the increasing the MAP by increasing the vasopressor, your target is your CRT is improved, or your lactate is improved. By what I mean is by
Perfusion improves.
Yeah. You continue with the same targeted MAP therapy, but you have to keep it in mind that we also need to see what are the impact of vasopressors per se. Now, this guy developed arrhythmia, then probably I would like to reduce the things. This patient develops mesenteric ischemia or digital ischemia or coronary ischemia. I would like to reduce the things. So, but this is one thing, but with a caveat that we need to keep it in mind that patients should not develop side effect from vasopressor. Neither the vasopressors nor the fluids, none of them are absolutely, charanamrit. They all have their own fallacies. So this is one thing. Maybe we can go out for half an hour to 2 hours, depending upon whether we were following CRT or.
So yeah, so
none of this trial is going to help. Whatever trial comes up, they are not going to help because they are not individualizing the things.
So maybe this is why we come to our next question, and That is what the Andromeda Shock 2 drill did. It was a personalized hemodynamic resuscitation. So, Professor Malbrain, you've been closely involved in physiological based resuscitation. As you also said in your initial take, you are not okay with the fixed dose of the 10 mils per kg as advised by the guidelines. So, what are the key takeaways from the Andromeda Shock 2 trial when they looked into the CRT personalized hemodynamic resuscitation?
Well, Supradip already discussed that. So for the Andromeda 2, I must say they tried to provide some guidance on how to personalize hemodynamic management with different tiers of treatment, looking at fluid responsiveness initially, also looking at cardiac condition, performing a dobutamine stress test or a noradrenaline stress test, especially in those who are very vasoplegic with low diastolic blood pressure. So it perfectly makes sense. But I think we could continue the discussion for hours to decide whether this was a positive trial or a negative trial. To me, I would say maybe it's a negative trial, and it's a good trial to provide some personalization in treatment. Because if you look at the outcomes and the composite outcomes, there is only a difference when it comes to ICU resource use and renal replacement therapy. So those are more the softer endpoints. But from a methodological perspective, I would say I like it, because we all talk about personalization, individualization, but at the end of the day, how? How are we going to do it for the individual patient at the bedside? So limitations, I think, by default, the Andromeda 2 was unblinded, and as said, and this is maybe a bit peculiar, the intervention was focused on the initial 6 hours, which would fit in severely shocked and septic patients, that you have these golden hour and golden hours to try to improve things. But nevertheless, what happens beyond time 7, and then we're thinking about negative effects of fluid accumulation, venous congestion, abdominal hypertension, I don't know, those things were not controlled for. So yeah, for me it's a negative trial, but an interesting attempt in order to provide guidance on how to personalize treatment based on a stepwise approach. And that I think is a good way.
Yeah, so they looked into the stroke volume, DAP, and the cardiac dysfunction. Accordingly, they decide whether the patient needs a fluid if the stroke volume is low, or if the patient needs vasopressor if the diastolic pressure is low, as you said it.
Dobutamine, yep.
And then if there's a cardiac dysfunction, as you said, they require a dobutamine. And the initial question what Supradip answered, in certain set of the patient, hypertensive patient, CKD patient, they did a noradrenaline stress test to lift the BP up for 1 hour, and if the perfusion improves, they continue with the same. If did not, then they came down. So they
Yep.
did present with the positive winning scores, but I think you have a different opinion over here for the same.
I absolutely second Manu.
Yeah,
I also
yeah.
think
I want to come with
it's a
the thought.
positive trial. It's not a positive trial. But it gives a beautiful physiological perspective. So look at the pulse pressure. Look, and it's a very simple bedside. So that way, it's very lucrative. No.
So we'll come to the next question, Dr. Apurba. In real world ICU with limited time and resources, we always look for the various fluid predictive responsive, PLR, ultrasound, PPV. So which bedside tool do you trust most to assess fluid responsiveness, Dr. Apurba?
Yeah, very good question. See, uh, see the diversity of population, right? And available resources, and access to the new updates, right? Those there are various factors that actually affect your personal choice, personal treatment, right? So this Andromeda with CRT, this is coming up, new thing, right? But for my My practice, this is personal. My practice, we believe, because we use ultrasound too much, because now it is very popular among intensivists. So, ultrasound and your inferior vena cava, finish. That is the mainstay, right? Number one point why I'm telling this as a very, very important for our bedside assessment of volume responsiveness, because accessibility, and you see the number of patients you see in a day. See, so ideal situation, everything is ideal, things will be little different, right? So this is my practice is check the ultrasound and IVC. Now what in IVC, what I need to see, what I want to see, is it the diameter, is it the collapsibility, is it the distensibility, right? These are very clear thing. But in practice, distensibility is difficult to see. So my personal uh, uh, opinion is only the diameter. I know I'm not totally right, but I believe in only the diameter, because see, I don't have a very ideal situation for collapsibility and distensibility, right? So you need to advance yourself a bit, because I'm talking about a middle level ICU with lots of resource limited. That is the maximum number of ICU in India, right? So if you go to literature, one very good test, that is PLR, passive leg rising test. That is very good, beautiful test. You can do in almost more than 70% patient. But obviously not all patients. Some patient there is a problem in moving your lower limb. Okay, problem keep aside, but this is one of the very good test. Now question is what you see with PLR. Now all literature, they say you see VTI, velocity time integral, that is your left ventricular outflow. That is very good. But what about only seeing the systolic BP? Is it okay? Now my question is, I think if you don't have expertise, so looking at the systolic blood pressure is equally good. So only thing you need to see whether this extra 300 ml of blood going into circulation actually doing anything to the patient or not. Anything means, is this fluid is actually making the hemodynamics better or not, right? So
So
that is our
we'll try, yeah.
fundamental
That
thing.
is so we look into the perfusion more than the filling up the patient. So I would
Correct.
like to have one more view, Professor Malbrain. Which baptized tool you feels is the predicts the fluid responsiveness best, and especially as Dr. Apurba say when we look into the resource limited settings. Professor Malbrain.
Well, first I would like to make a comment.
Yeah, please.
I'm not interested in fluid responsiveness. Why? Because that is the normal situation. We are all fluid responsive
Responsive, as we
as I
spoke in the
speak.
end. Yeah.
I hope we are on the steep part of the Frank Starling. I'm more interested in fluid unresponsiveness. So a test being negative as a safety parameter for maybe stopping to give fluids, thinking about restriction, withholding, withdrawing, de-escalation, de-resuscitation, because that's a major problem when compared to resuscitation fluids that may only account for 6% or 10% of the total amount of fluids that we were given. As Supradip mentioned, on the indication depends the goal why you're giving fluids. But if I would like to pick one test, then I would go for the passive leg raising test. And when it's negative, it may tell me that this patient is ready for de-resuscitation. If you have in low middle income countries, I think an A line is possible. If an A line is possible, with modern monitors, you can have continuous PPV additionally to that. So PPV is a second in line with a lot of limitations, I know, but you can twist it around. If the patient has arrhythmia, you expect PPV to be high, but if your patient has a very low, then it definitely tells you that the patient is not a fluid responder. So I always like to
So your
turn
target
it
varies
around.
as per the patient, and you look into the variation in the target. So as you rightly said, maybe my target is 12, but if someone whose arrhythmic target would be 16, yeah.
Yes, in abdominal hypertension, you may have a target of 20, 25%. Yeah, sure.
Accordingly, we have to interpret. Very rightly said, and it's an amazing point. And PPV, SPV, Dr. Srinath is also looks better, especially if there's an arterial line, and it's easy for the nursing staff as well. You don't need someone really expert over there sitting over there. Just a monitor will tell you.
Bharat, can I
Yeah,
just
please, sir, please.
one more? So this day, I am currently I'm working in a very small ICU, and it's not high
No,
flying.
ICU is small, sir. ICU is
What
all.
I'm using is I'm using the changes in VTI with respiratory variation. The VTI is a surrogate of stroke volume. So we see the VTI. I don't have any standardized way to look into the things. But if the VTI variation is very, very low, we all are having ultrasound machine these days in the ICUs, majority of the ICU, even in the resource limited setting. So if we can do the IVC, we can also look at the VTI. So VTI.
Yes, and you can combine it with a passive leg raise. You can do
But sometimes this is one thing we can look into this. Passive leg raising with VTI is something which can look into it. Another thing is sometimes if you really want to look for the fluid responsiveness, not fluid unresponsiveness, but really in some cases you want to look for the fluid responsiveness, then you can look for, sometimes you don't have any facility, but to give a fluid challenge, the standard fluid challenge as suggested by Maxeri Weld, that fluid challenge with VTI.
So what is standard fluid challenge? That is also a big question. Please clear it out.
No, it's
how much then whatever what is typically
the standard.
also discrepancy in that.
It works. It works. The trawl really works. It still works in certain situations. Even today, I had a problem with a patient where I was not sure whether to give fluid or whether to increase the vasopressor. And as I said, the limitations are there in many of these settings. So ultrasound is a unique tool, and ultrasound can be utilized in many, many different ways. A lines, B lines.
I agree with Supradip. So, but if you talk about a fluid challenge, you always assess before the fluid responsiveness, the volemia, the perfusion, and so forth. You do the challenge, and then you check again. And you could even use CVP for that.
Yes.
Based on your starting CVP, below 8 you give 4 ml, 8-12 you give 2 ml per kg, and above 12 you give 1 ml. And then you see at the delta of your CVP. If it increases with more than 5, then stop, because you're at the right side of your filling curve. So dynamic tests, yes. Static tests, no.
No. Only issue of CVP is the measurement of the CVP, how to measure, where to find out the end expiratory, end of expiration. So these technical issues are there when you are using the machine, the monitor to guide you the CVP. That's the problem. So, but ultrasound is better.
So, Professor Manu, I mean, you were answering one thing. So Dr. Kavita has also said the same. Can we check PLR with PPV with arterial line? So especially if you could answer that. PLR with PPV, what you just commented.
Sorry, what is the question?
PLR with the PPV with arterial line, can we combine the two?
Well, if you only have the A line, you only have the pressure. And you cannot look at an increase in pressure as a surrogate for flow. That's the problem, especially if you have old patients with stiff arteries. You may see increase in pressure, but you're turning the patient into pulmonary edema instead of being fluid responsive. So for the passive leg raise, you need to have a surrogate for stroke volume. And I think VTI would be a possibility. Looking at relative changes of PPV could be a surrogate, because under your arterial curve you have a stroke volume as well. If that is the question, looking at A-line arterial pressure when you do the passive leg raise, that we cannot recommend. But looking at PPV, looking at maybe saturation, PVI, plethysmographic signs, looking at VTI with ultrasound, yes. If you have non-invasive cardiac output or pulse control cardiac output, then yes, of course, you can use.
I think the original study about the PLR, what they found is when they compared it with the pulse pressure, the AUC under ROC was below 0.8. So I don't think it's a great test. If you
But
are
PPV, you can, but
change in the
not
pains
the pressure.
Then also you found that in that particular study they found it was 0.8. Not a great test, but yes, when you don't have anything else, what to do?
We'll move to our next question. When we talk of all these indices, so we all know the echo indices for the fluid decision. So, Dr. Sunil, from a practical echo perspective, with parameters actually guide your fluid decisions reliably, which are the most reliable guiding fluid decision in real world ICU when it comes to the echocardiography, Dr. Sunil?
Sure. I think most of it has already been
I think
touched upon in bits and pieces. So I'll just summarize it.
Yeah, please.
I mean, again, as I think you use the word practical, so I'll stick to the word practical. So if you look at static indices, definitely indicative would be a very small IVC diameter. I'm not too sure about the collapsibility, distensibility index in the current context, particularly collapsibility is certainly, I think, more and more obsolete now because it's as good as something 0.55. We're looking at the ROC or the sensitivity of that. But I think a very small IVC in the context or less than 1 centimeter, let me say, in the context of somebody who is hypotensive will be one of the indicators. I think a better predictable indicator would be looking at the advantage of the echo, of course, is looking at the LV chamber size, LV and the RV. If you have a very small end diastolic area or an end diastolic volume, particularly area, then you know that you have a situation where the LV is empty, where we call it as the LV kissing sign. If you have a VTI which is low in the context of an ejection fraction which is looking normal, I think that is something you would consider that, or for that matter, a hyperdynamic looking LV with an VTI which is low would indicate that there is hypovolemia definitely. I think as Professor Malbrain and Dr. Supradip mentioned about the utility of VTI in the context of PLR or the utility of VTI in mechanical ventilation when there is a variation of more than 10%. I think both these would indicate that the person could be fluid responsive. A very small RV again could be indicative. I would even go to the extent of saying that it is not enough if you just look at the echo parameters, but I think it's also highly important to look at the congestion parameter, particularly if you find that the lung is wet or you have suggestion of a significantly volume fluid overloaded lung of whatever reason, could be cardiac related or non-cardiogenic, whatever. I think then we will be a little more cautious in interpreting whether we give fluid or not. So I think that is something we will definitely look at before we decide, just not only based on the indices of echocardiography or all those that indicate fluid responsiveness, but also look at the congestion parameters. So these are a few things that I would touch upon.
So I'll take one question on this. So it's by Dr. Rakesh Periwal, who asks, carotid VTI any takers as compared to the aortic, that is LVOT VTI?
So it's found to be equi-efficacious, but a little difficult to do in all circumstances. So I think it's much easier to do the LVOT VTI, but it is almost, it's not like significantly better if you look at that. But there are certain specific areas like, if you're looking to assess the perfusion and things like that, there is some role. But as it is, I would say it is not much more better than the normal LVOT VTI, but I'm subject to correction.
Yeah, please.
One thing I want to add here, I have not used that device that called flow patch.
Flow track.
I have not used it. I have seen in literature. It's a wireless carotid Doppler, basically. It can show you same VTI, so maybe it looks like, very useful. And one more thing that is, again, I have not seen this bioreactance monitoring. When it's non-invasive, because it's non-invasive, that's why I'm mentioning it. I have not seen it, nor used it. You can put two pad over chest, and it will measure the stroke volume, right? Moment you do PLR, if the volume is increasing, that's again a very good indicator. But I have not seen. I'm just telling you because
Yes, yes,
it looks
we
very
all,
interesting.
yes,
But
yes, we
very
all,
little data in ICU. I think
yeah,
most of the data available is from non-ICU
on
patients.
ICU,
So, because there's a lot of other interferences that happen in the ICU patients. So,
bioimpedance,
I think we need more technological improvement or more data before we start using it in the ICU.
ICU.
Yeah.
We'll move on to the next question, that is, when does fluid stop being therapy and start becoming toxic? So, as was spoken of by Professor Malbrain and even the Supradip seconded it. So, uh, I would like to have input from both of you. So, what are your red flags to stop the fluids? I mean, as you both said, I have to look into the fluid unresponsiveness, not the fluid. Maybe Supradip, you can go first, and then I'll have Professor Malbrain's view on this.
So first thing is we cannot just continue with the fluid therapy. And most of the focus as of now is on resuscitation fluid. Whereas, as Manu has pointed out, resuscitation fluid is only 6%, only 6 or 7% of the overall fluid volume, whatever we give. And we give a lot of maintenance fluid, which probably are not required. We give a lot of, these fluids in the form of dilution, fluid in the form of many other things. So these are not required. So this needs to be curtailed, number one. Number two, even for, let's come to the resuscitation. As soon as patient's perfusion is achieved, we need to stop giving fluid. Give fluid, whatever you give, this will get accumulated. That will cause fluid accumulation. And whether sometimes organ damage occurs and we may not be able to pick it up. But at the macro level, the organ damage is still occurring because of whatever we are giving when it is not required. So we need to stop in those sentences. And now, when do we start the grossly? When you see some organ dysfunction, for example, patient has got intra-abdominal pressure, which is up, patient intraocular pressure is up, patient is showing the obviously looking edematous, patient is becoming hypoxic, then it's okay. Then you look for the organ, whatever, whether there is a congestion or not, or whether systemic congestion is there or pulmonary congestion is there. You also look for the pressure in the right side or the left side of the heart. If there is a pressure in the right-sided pressure, if you have a CVP in place or IVC is in place, or you see whatever all these pressure, the pressures are going up. Directly you measure or look for the IVC, whether the IVC is more than 2 centimeter or is a plethoric IVC, or so right-sided pressures are. We go for some, like you can go for an ultrasound with a VEXAS, or you look for the congestion of the hepatic veins, renal vein, or portal vein. In the left side, you look for the V profile and see the things. So this patient is, the organ dysfunctions are occurring because of the iatrogenic fluid overload. Second thing, okay, so should we remove fluid? Should we go for the deresuscitation? To go for the deresuscitation, we need to see, okay, whether, okay, patient is congested, but whether if we remove fluid, whether it will cause further perfusion problem or not. So one of the things what Manu has mentioned, if you look into the patients who is fluid unresponsive plus congested organ, it's the right time to go for deresuscitation, either with a volume, either with a furosemide or diuretics, or some cases ultrafiltration. So look for the left-sided pressure as well as right-sided pressure. Look for the organ congestion. Look for the fluid unresponsiveness and go for diuretics. So probably this can be one of the ways by which you can go for the things.
Professor Malbrain, you want to add something to this? Or want to summarize?
Of course, yes. No, I fully agree with Supradip. I would like to say one thing. So we call it deresuscitation or late goal-directed fluid removal. Only when the patient has no longer shock. So assuming that acute circulatory failure has been resolved, when there are signs of hypervolemia, when there is normal tissue perfusion, so usually capillary refill, maybe normal lactate below 2.5, when the patient is fluid unresponsive. There are signs of fluid intolerance. You could use a Vexus score or POCUS or whatever you want. And the patient is at risk for fluid accumulation syndrome. Why is that? Because many patients can have a positive cumulative fluid balance, but they are breathing at 2 liters of oxygen and they are not in distress. It's only the ones, as Supradip said, who have an impact of the accumulated fluids on end organ function. Now, if you want, for my 50 cents, what parameters do I choose? Clinical, body weight, daily, fluid balance, daily, cumulative, bioelectrical impedance analysis, daily or every 2 days. And then I pick the absence of fluid responsiveness. Now, PPV that is low, passive leg raise that is negative, high barometric preload like CVP, high volumetric one like end-diastolic volumes, and the extravascular lung water. This, in combination with the most important vital sign, which is increases in intra-abdominal pressure, those are for me the red flags when you start thinking about active fluid removal.
So I would like you to continue on this. So there are various resuscitation phase what we use into, and various tools and targets across the different phases of the shock. So how do you use these targets change, or how these targets change from the rescue phase to destabilization to de-resuscitation?
Is a very good point, and this is the whole thing. This is the dynamics of fluid management. Is not confined to one phase. You don't have
and
one
also
size
would
that
like to
fits,
have one comment on the
that fits
maintenance
all.
fluid in the same. Also would like to have one comment on the maintenance fluid in the same scenario.
Yeah. So salvage, resuscitation to save lives. Here, talking about fluid responsiveness, so the conditions that needs to be met, it's the opposite. So the patient need to be in shock, hypovolemic, tissue hypoperfusion, CRT or lactate, whatever you want, should be fluid responsive, fluid tolerant, and no risk for fluid accumulation syndrome. This is the conditions before which you check, and if those are met, you can safely start and resuscitate. So you need to have endpoints of perfusion. You pick one, but I think usually we have lactate and capillary refill time. And you need to monitor cardiac output. And this was in the latest update of the European Society Hemodynamic Shock Consensus Guidelines, is that you need to have some estimate of cardiac output. You could use ultrasound for that, but that is not a monitor, it's intermittent diagnosis. So that is for the resuscitation. So optimization is when shock has resolved, when you see that lactate normalizes, blood pressure improves, then you're gonna try to achieve a zero fluid balance. So the cumulative fluid balance will still be positive, but your daily balance should be neutral. And optimization, stabilization, I know different phases, but in real life, it's not so easy to separate them. It's the time when you achieve homeostasis, electrolyte acid-base balance is again in balance. You can start some enteral nutrition and you switch from IV to oral treatment. And the de-escalation, usually most of the patients will get rid of the excess fluids and everything that we do in an iatrogenic way, but the ones that need some help with active fluid removal, we already mentioned the conditions that need to be present before even thinking about de-resuscitation, because it's also an active treatment. It's also a drug with indications, contraindications, and potential adverse effects.
And a comment on, is it necessary to always use a maintenance fluid in the ICU? What we
No. Absolutely not. as already was mentioned, 6% of all fluids is for resuscitation, maybe 6 to 10%. Maintenance replacement is 25, nutrition 33, and the big vast amount is creep fluids. We didn't discuss it. It's the little bags that you use to dilute other drugs, antibiotics, painkillers. Some pharmacists I spoke with dilute vancomycin 500 milligrams in 500 ml of saline. So if you would need to give 2 grams a day, it's 2 liters of saline. But the perception of the doctor is, I'm giving vancomycin. I'm not giving 2 liters of saline. So they seep into the patient without us even noticing it. So maintenance only needed when there is nil per mouth and there are no other sources of fluid intake. But if the patient gets paracetamol, if he gets antibiotics intravenously, you just need to make your calculations right, and maintenance should cover the daily needs. So 25, 30 ml per kg per day, that's enough. So most of the patients, no need for maintenance. And if they would need it, I'm not talking about the neurocritical care, go for a hypertonic balanced maintenance solutions according to the NICE guidance. So it's glucose 4%, 0.18, NaCl with a little bit of potassium. Don't give saline in glucose as maintenance. Don't give ringer or plasma light in glucose as maintenance, which is done very, very frequently, even without the glucose.
So important, very important point which has been brought in. I don't know. So we'll move on to the next question. One second, I might have to mute everyone. Yes. So we'll move on to the next question. That is early norepinephrine to avoid overload. So Dr. Apurba, should if you could tell us fast, should we be starting norepinephrine earlier to prevent fluid overload, or how do we identify such patients?
Yeah, I think the answer is very clear cut. Yes, norepinephrine should be started earlier to avoid volume overload. Actually, it has lots of good thing using vasopressor, because you are actually, see, the confusing point here is either you are targeting pressure or perfusion, right? So that makes the whole things little confused. While using noradrenaline, that means you are actually targeting the pressure. Actually not. You are actually trying to maintain the vascular tone at the same time and reaching some amount of good cardiac output at the same time. So using it early, yes, I think is beneficial for patient, but you need to be very careful about giving in a very high dose. So it's a low dose noradrenaline. Yes, it can be used in early in the course.
Thank you.
Bharat, I would like to
Yeah,
add
yeah,
here.
please add.
So for the sake of, I think there are many students. So if it is an extremely vasodilated state, norepinephrine should be the default
So
treatment
that
of
means
choice,
you
not
also
the.
tell them
How
vasodilatory
do you go
vacancy.
for a
You also
extremely
tell them how do
vasodilated?
they look into the vasodilatory
Yeah.
for
So
the
if
sake
the
of
diastolic blood pressure is very low, if the diastolic blood pressure is, say, can't have an exact number, but maybe till now
less than
less than
50, so they
40,
want to took it in
always
the
less than 50. Why they have less than 50? Because they have seen in PPH patients, and patients with PPH were actually young ladies. Then when the diastolic blood pressure goes down below 50 millimeter of mercury, troponin starts rising. So diastolic blood pressure has to be kept below more than 50 or more than 40 millimeter mercury. So this is when you have to start norepinephrine immediately. If the pulse pressure is very wide, again, no value, exact value, but if it is very wide, the likely that this patient is vasodilated.
Yeah, so very rightly said. To summarize, we look into the perfusion, so we don't wait for the whole fluid bolus to finish. You cannot allow your patient to be hypotensive for a longer duration to allow your organ to get damaged. So start early, and then you can come down as you finish the resuscitation, as Dr. Supradip said it at the end. So we come to the now boluses. We've spoken about the various boluses: liberal strategy, restrictive strategy. Professor Malbrain, this 30 ml per kilogram rule is widely taught, but I just want to understand where this 30 ml comes from and why is it being questioned now?
That's a good question. I don't know where it comes from. I couldn't retrieve it. It seems like a magic number. It's standardized, it's protocolized, so I do not like it, especially not if they change the guidance from 3 hours to 1 hour for everyone. I think it fits within the debate that we cannot advocate as no one size fits all. There was in the initial sepsis guidelines a statement on the CVP 8 to 12, and that referred to a paper looking at the wedge, which came from a tail of 6 mares. So in some horses, they looked at the relation between pressures and filling. Yeah, can we forget about it? Can we not do that?
We must. We must.
Because otherwise we're going to drown patients and other patients will remain unresuscitated. But I have to tell you that my very good friend Xavier Monet did a study in septic patients, and what he found on average was 30 ml per kg. But some were doing fine with 10, or were having already too much with 15. You know, there is a big spread. But on average, it was exactly 30.
So, I as a moderator cannot comment on it, panelists can.
Well, it's like the statistician that drowns in a lake with an average depth of 30 centimeters, you know?
Yeah, anyone from the panel want to comment? Dr. Sunil, Pankaj, Apurba?
See,
I think
I personally
30 is a good number. Sorry.
Yeah, please carry on.
Yeah, no, 30 is a good number. But my thought is it is going to change in the next guideline. So let's wait for the one which is going to come. But yeah, I think it's better to be using the different tools that we have for guidance. And we even have guidelines now for resource limited settings. Maybe not very robust, but there is some suggestion, capillary refill, few things. So I think based on those or a conglomerate of indices, we should come to a judgment call. As I told, even during echo, you might find VTI is low, but the lung is flooded. So we might decide not to give more fluid. So I think it is going to be precision based, individualizing to each and every patient. Not only that, I would say even in a given phase of sepsis or whatever shock, there could be variations. If there is resuscitation now, an hour and a half later, we may not be doing it. Or you might find that you have been a bit, stingy with fluids, the patient gets intubated for whatever reason, you have more space to give fluids. So I think all these things have to be considered when we talk about, fluid giving, not giving, even if it is in the early phase, I would say.
Yeah, agree. Just common sense. I think we
Yeah.
all have a brain, so we just need to use it and use it to personalize the treatment. I have an advantage because I have a brain in my name, Malbrain.
True.
So I had a point, Bharat.
Yeah, please, sir. We need to add brain in
30 ml is
very
too
simple
much.
name.
30 ml, but you need to go for a particular number for the students, for the younger people. So one of the
10.
that
Start
Holman
with
Aya,
10 ml per
Yeah.
kg.
4 ml
Reassess.
per kg is perfect.
Oh.
Not even 10, 4 ml per kg. The Holman Aya, this group of researcher, those days,
Yeah, 4 ml sequentially, and you accumulate
sequentially.
until 10, and at 10 you start thinking maybe pressors and other things.
Yes.
Yeah.
So you start with 4 ml, look for the response, and go for this maximum up to 10 ml, and then it is time that you should think about something else.
Yes. And again, this all should be done within some particular time, 10 to 15 minutes. They cannot keep on doing it for next half an hour or 1 hour.
That also, I would say, it depends on the situation, clinical
Exactly.
No, if
situation.
there's an hypotension, if there's a persistent hypotension,
Yeah,
we're talking
yeah.
of a situation when there's a
So,
persistent
see,
hypotension.
I'm sure on the pragmatic terms, most
Instead
of the
of
time we would have
hypotension,
started
can
some
we switch
NORAD.
it to persistent hypoperfusion?
Yeah.
Not hypotension,
Hypoperfusion.
persistent
Hypoperfusion.
hypoperfusion.
Yes.
So, yeah, thanks for correcting me. So when there's a persistent hypoperfusion, then we should think of switching to vasopressors earlier than waiting for
Yes, sir.
So now we'll move to the next part. We all spoke about to give, not to give, when to give, and how to prioritize, how to resuscitate. Now, what should be given? So, which fluid strategy differ in different types of? I mean, the last question is about in this topic is so there are various types of shocks available. So, septic shock, cardiogenic shock. So, how should the fluid strategy differ in different types of shock?
Who's the question for?
Yeah, question is for Sunil.
Yeah, right. So I think
One second, let me
somebody
mute
needs to be
everyone
muted.
again.
1 minute. Yeah.
I've done that. You have to unmute yourself, Dr. Sunil. Yeah, because I had to mute everyone. Unmute yourself.
Okay.
Yes.
Can you hear me? Great. Thanks.
Yeah.
So I think the fluid strategy again, it's very broad question, I would say, to actually say that, what is the strategy different. But let us broadly put it. Yes, hypovolumic, we know we would give fluid. Now, what type of fluid will depend on what is lost. I think the simplistic rule is to say you lose blood, you give blood, you lose crystalloid, you give crystalloid. So that is going to be bottom line. Definitely no synthetic colloids. I think that's where we end. Septic shock, it depends on what stage we are talking about, and we have spoken a lot about sepsis. The guidelines are there. So definitely early on, the trend will be to give fluid. How much fluid is again going to be decided on the dynamic indices that we talk about. And whether it's 10 ml per kg, the minimum max of whatever, I think that's something we would assess this thing. Again, in sepsis, we depend on which stage of sepsis we are on. Is there an associated cardiomyopathy or a cardiac dysfunction underlying as a consequence of sepsis? So all these needs to be considered as well. If we come to obstructive shock, I think early on there is some role for fluid, cautiously watching the septum. If you find that you are actually over distending the RV, there's a shift of the septum too much to the right, then of course you would start backing off on that. And this holds good even for an inferior wall or a right ventricular myocardial infarction. So this is one place probably there is role for fluid to be given, and as and when you find that there is filling happening, you would probably restrict it and go more towards an inotrope of sorts. And cardiogenic generally restrictive, but if the cardiogenic is, if you think that a person who has cardiac dysfunction has an associated hypovolemia, either absolute or relative, then you would probably look at giving mini fluid challenge and looking at the assessment. So there, I think there is a big role for dynamic indices. I would even say this is one place probably there is role for more complex monitorings like cardiac output, or something which will give us a little more indication, especially if you're talking about a mixed shock, cardiac with hypovolemia, cardiac with sepsis. This is one place where probably sometimes interpretation might become a bit challenging. But I think on the whole, important to be remembered at the back of the mind is fluid responsiveness there, not there. That's the fundamental question we need to answer. I hope I
Yes.
could
Yeah.
answer it in a
Yes,
brief.
it's very well, sir. I mean, the
Yeah.
fundamentally you close it, we again have to look for the fluid responsiveness and the
Yeah.
tolerance and not the toxication. So we are well beyond the time. We'll finish next questions a little faster, and those are easier ones as well. We spoke about when to give fluid and when to stop and resuscitate. So what to give? So Dr. Pankaj, what what to choose between the balanced crystalloids and versus the normal saline? Debate is always on. So what do you do in your practice?
This debate is not going to over soon. First thing is very clear about. The point is, like, we want to give uh, isotonic and isobaric fluid to the patient. That is the simple concept to us. So when we are giving fluid, so like I will use normal saline. If I want to give, say, 1 liter of fluid total, I will use normal saline. But if I'm dealing some trauma patient or a patient with a hypovolemic shock or a cholera sort of scenario where I need to give more fluid to the patient and I want to give crystalloid, so I will go with the balanced fluid. So we have to see, we should be very clear that no fluid, because in a Indian context we should remember that cost is also involved here. Like the normal saline is a 20 rupee thing and the balanced fluid is 300 rupees in India. So I will use for say first 1 liter. If my patient is having the shock because of, say, cardiac, I can use normal saline. I don't have any issue with that, because anyways I will start at the pressors bit earlier. But if I have to treat the trauma or the sepsis or the hypovolemia because of any other reason or the distributive shock, I will go for balanced fluid by giving little early normal saline, because that is what I do in my practice, and the debate is still on.
Let's not forget Ringal lactate is
Yeah,
also
I was coming to that.
lactated Ringal solution is also a balanced solution.
Yes.
And that
Yeah,
costs
yeah.
35 rupees or maybe 30 rupees.
But it's a bit hypotonic.
It's a bit hypotonic, so
Hypotonic.
let's
It's
not give it in the
hypotonic.
head injured patient. But when there is a cost constraint and we have choice of giving either a saline or Ringal lactate,
Ab-
I think why not
Absolutely.
go for a Ringal lactate?
Yeah, yeah,
And you
absolutely.
don't have a cost constraint, and you are
No
anyway
excuse.
going to you are anyway going to give a liter or 1.5 liter of fluid at the max. So and we are already spending so much of money on
I see.
antibiotics. So how does it matter even if you give a little bit of plasma light or a little bit of stirofundine or isofundine?
So in the
Well,
context of
600 rupees, 900 rupees.
so sir, in the
And
context of
if the
different
cost is still a constraint, the Ringal lactate, the good old Ringal lactate is fine.
yeah, so in the
Why to
context of
go
the
for
different
saline? Why
trials,
to go for saline at all?
that is saline versus that is in crystalloid, that is saline versus a balance on solutions. As you rightly said, Ringal lactate can be used, but we have to be very sure it's hypotonic. So in certain cases, we need to avoid it. But in most of the cases, just the requirement of fluid is somewhere around 2 liters. This comes from the post hoc analysis of the different trials. I am subject to the correction as well. So when the requirement of the fluid is less than 2 liters a day, then the normal saline also does well. But when the requirement is more than 3 liters in case of the diabetic ketoacidosis, renal recipient patients, or high volume resuscitation, there is where the normal saline, maybe because of hypercholemic acidosis, there are changes in different modalities. Maybe the RRT is more, in cases length of stay is more. So over and all, normal saline can be used, especially when we have to give high boluses. We might switch to the balanced crystalloids, including RL, but again, not in cases where hypotoning fluids are to be avoided. Is that okay?
I just
So-
have a point. These 2 liters, because many of these studies, including the first one from the Australia, New Zealand, they have used only 2 liters. But we are using only creatinine as the parameters. But how do you know whether these 2 liters are actually causing harm to our patients? Maybe creatinine is not rising, but maybe they are contributing to some amount of renal injury. What about the individual patient level? There is a strong physiological rationale that giving too much of chloride can be detrimental.
Yes.
So I think by and large we should get away, unless it is, somebody is hypovolemic hyponatremia or somebody has got chloride responsive metabolic alkalosis. These are the different scenarios. Otherwise, why should we give a drug which has got a propensity to produce certain amount of harm to our patients? Just say that because up to 2 liters it doesn't matter. How do you know it doesn't matter? You have not checked the real, the more finer renal parameters to judge the things.
Yeah, agree. So no place for saline, not for little bags, not for 1 liter or 2 liter. It's not physiologic. It's abnormal. Why would you do that? Don't do it.
All right.
And
So
if
very
Ringer's
clear message, we have
lactate
it over
costs,
here.
if
Very
Ringer's
clear
lactate
message.
costs the same, give that. And dilute all your drugs in glucose, not saline. Most of the drugs can be diluted in glucose, and you can even concentrate them up to the level of a syringe and give it in a slow IV bolus to avoid the creep.
So we'll move to the next question. We all know we've not been using colloids, but what about the albumin? So Dr. Apurba, where do colloids or albumin still fit in the modern ICU practice, if at all?
Colloid actually, because of this renal thing, it is out of practice. I have not used colloid in my ICU. Yeah, albumin has a role. Typically, we are using in situation where we are using lots of fluids, right? So to decrease a huge use of crystalloid, we can use albumin. We can that is one indication. Second, we are using in when the fluids are outside your vascular area, there you can in a process of de-resuscitation, the combination of albumin and a diuretic. That is one indication where we use albumin. So these are two main indication, and those situations where hepatic, like hepatorenal syndrome, you are doing lots of ascitic tapping. In those situations, it's very common. Everyone is using that. I'm just mentioning it. So albumin has still role in ICU. Other colloids, I don't know.
All right. So Dr. Supradip, Professor Malbrain, you want to add something to this?
So albumin probably has got, as rightly pointed out, definitely in the liver patients with hepatorenal syndrome, spontaneous bacterial peritonitis, large paracentesis, they have class 1 indications. There is no doubt about it. And plasmapheresis, but in ICU scenario, one role I would like to point out, and I've been
Also
using
clear one situation question is, we have 5% or 20%. Which one?
5% I hardly use, but 25% is a role in the burn resuscitation. I think now we have enough data for supplementing 5% albumin when you are exceeding IV index. That means when you are anticipating that these patients, a burn patient with more than 20% burn, have a expected fluid volume of more than 250 ml per kg in 24 hours. In such patients, along with Ringer's lactate, you can give 5% albumin. So apart from that, there is a role for hyper-oncotic albumin. Hyper-oncotic, there are small little studies, like one of the studies, the SWIPE study, where if you can give hyper-oncotic albumin in your, say, when you have given a little bit of IV fluid, already crystalloids have been given a liter of crystalloid, but the patient still continues to be fluid responsive, and patient, there is no evidence of fluid tolerance, and patient is hypoperfused. Instead of going for further crystalloid, you can go for a bolus of 20% or 25% albumin. But there is a caveat. There are some data which shows that when you go for hyper-oncotic solution, there is a higher risk of acute kidney injury. So we need more data to supplement the things, but this can have a role in this. So maybe one of this. And Dr. Bora has already pointed out very strongly that Manu has done this PAL concept, where when you go for the de-resuscitation, and there are many other studies that if you go for albumin during de-resuscitation, there is a lower risk of hypotension during de-resuscitation. So I think there is a study from US where they have shown in a nephrology subgroup. And so this is, again, de-resuscitation, there is a role of 20%, 25% albumin. But this role of 20 or 25% albumin for reducing the cumulative fluid balance need more data. And this is probably something which is coming up.
Yep, I agree. The only thing I would like to add, only give it when your serum albumin levels are low, below 25, 20 grams per liter. Don't give it when they are normal. But
If at all we have to give, we just don't have to follow the serum albumin levels and decide the.
No. If you want to give it for a reason to de-resuscitate and so forth,
yes,
you have an indication, but then you check the albumin levels. If they are normal, then don't give it.
All right.
You should never give it for the cosmetics of a low albumin level.
That's what the
of course not. Of course not.
So we'll move to the, we have discussed all this drug dose and duration. So, and for the lack of the time, I'll move to the last question. What should ICU trainees learn about the therapy? Dr. Manu, Professor Manu, Malbrain, please, if you could tell this.
Unlearn. So what they should forget. Well, it's difficult. No, I don't want them to forget things. I want them to remember. To remember today that we spoke about fluids, and fluids are drugs. So they come with indications, contraindications, potential adverse events. And I would like to invite all junior doctors here today to sign up to become a fluid champion. Go to the Fluid Academy. It's free. It's 12.5 CME hours you get at the end of the day. You will be a champion. And I'm going to say more. If those junior doctors can identify colleagues, doctors, nurse, dietitian, pharmacist, maybe an IT guy in the hospital, then they can build a core fluid stewardship team to start the path to become a center of excellence and train the trainer and teach the teacher. Because it's all about giving the right fluid for the right indication with the right concentration, the right tonicity we spoke about, right and rate, for the right duration and de-escalation in the right patient at the right time. That's fluid stewardship. It's about the 10 rights.
Yeah, thank you very much. And so I would say unlearn about the use of normal saline routinely, unlearn about the maintenance fluid what we usually practice.
Yeah.
And learn about diluting vancomycin in half a liter of saline, dilute in glucose. Stop fluids to keep lines open, flushes, all these kinds of things. But I think they are smart enough and they have learned and understood everything very well.
Thank you to our wonderful panelists for sharing their insights, and to everyone who joined us today. So fluid therapy, as you all know, is not just about the volume, it's about understanding physiology, perfusion, and recognizing limits. And we hope today's discussion help you look beyond numbers and protocols and make more thoughtful, patient-centered decisions in your ICU practice. So thank you very much. We'll be announcing our next Critical Care Unplugged webinar very soon. So please stay tuned until we meet again. Unplug from habit, reconnect with physiology, and always strive to find the balance. Thank you and have a great evening.
Thank you.
Thank
Thank
you.
you.
Bharat.
Thank you.
Thank
Thank you so
Thank you,
much for
Bharat.
organizing such event.
Bye-bye.
And see you, Manu, sometimes.
Yep,
Nice
absolutely.
catching up with
Maybe
you.
in India someday.
Yeah.
Someday we'll do it something. We'll
And
do
Bharat will
something.
become
Yeah.
the chairman
Yeah.
of our, he's going to become the next president of our society.
Thank you.
So,
Thank you, Dada. Amen.
Bharat,
Thank you, Dr.
okay.
Manu and Dr. Subhutra and Dr. Bharat. Thank you very much.
Thank you very
You
much.
all.
Thank you.
Bye-bye. Thank
Bye.
you.
Thank you.
Bye. Thank you.
Thanks, everyone. Yeah.